So let's go ahead and get started. Um, if you can help me while I'm talking, if you see anyone in the waiting room and invite them in. Um,
For
thanks
sure.
for Thank you. Thanks everyone for joining for our Seven Starling webinar series designed to give you healthcare providers pearls to help you feel more confident in supporting your patients with mood and anxiety disorders across the reproductive lifespan. I'm Dr. Nazanin Homafar. I'm a board certified OBGYN and I'm medical director at Seven Starling. Many of you are probably familiar. Seven Starling is a virtual mental health clinic that treats those experiencing anxiety, depression, and trauma throughout fertility challenges, pregnancy loss and miscarriage, and postpartum. And most recently, when we announced that we're offering care for mothers with children up to the age of 5. I'm honored to be joined by Dr. Crystal Clark, who is an associate professor of psychiatry at the University of Toronto, an associate head of research at Women's College Hospital. She's dedicated her career to reproductive psychiatry and the advancement of maternal mental health as a researcher, educator, clinician, and thought leader. And she's also an advisor to Seven Starling. She wears many hats. And today we're talking about SSRIs. We've had this webinar before. It's been a
Mhm.
while. And it's always a very popular one because I think people want tools. And I've certainly taken the tools that I've learned from this webinar to my everyday
Mhm.
practice. I want us to cover, we have 45 minutes. We went from doing 30-minute webinars to 45 minutes, but I'd like for us to cover the basics of prescribing selective serotonin reuptake inhibitors for perinatal and postpartum anxiety and depression. I also want us to try and touch on bupropion today if we can. That's not one that we've really
Yeah.
discussed.
Mhm.
We know that SSRIs are the mainstay of pharmacologic treatment for perinatal depression and anxiety, and as a complement to therapy or potentially on its own. And I think many of us are probably in
In
practices
practice.
where, is that you or is that me? I can hear myself. Or we're in practices where we're seeing, oh, not. Um, where we're seeing patients, probably screening them, and would love to, instead of, some of us have 4 to 6 week waits before they can see someone like you, we'd love to be able to start someone on something. Um, there's a shortage of reproductive psychiatrists in the US, and there's several initiatives trying to focus on training up other providers. So let's start. Let's start by talking about them.
All
I
right. Are you still hearing the echo?
No, it's gone
Okay.
now.
Okay.
I was hoping we could start off by discussing when do you recommend prescribing SSRIs for patients who are pregnant or postpartum? Is it going to be based on their scores? How long do you usually wait to let something like talk therapy work if they're seeing someone? Give us a little bit
Mhm.
about how you approach this.
Yeah, so how I approach it, and this is consistent across guidelines and how many of us, with some caveats to the individual and to the provider's particular preference of doing things. But the rubric I would start with saying is, mild cases, we start with therapy. So no significant impairment, scoring mildly on the our typical screens like the GAD-7, that's the Generalized Anxiety Disorder Questionnaire, which is a 7-item questionnaire. The EPDS, the Edinburgh we call it prenatal and postnatal now depression scale, and the PHQ-9 which is the peer health questionnaire. I can get into what moderate and mild, moderate, and severe mean on those scales specifically, but I want everyone to just think that the rubric is, mild cases, therapy is often the best place to start, and that probably is going to feel most comfortable for most patients, especially if it's a new onset and they are not excited to take medications. Um, Moderate to severe, however, is typically where we choose to start an SSRI or some type of antidepressant medication, partly because the symptoms are obviously more severe. Therapy is going to take longer to treat those. For your more severe cases, therapy just won't be enough to treat those cases. And so medication is going to be very key for those patients.
That's helpful to know. So what would be, sorry, toggling the waiting room and talking to you. So I'm hearing very clearly moderate to severe symptomology. How would like, let's say someone started talk therapy. How long would
Mhm.
you give that? How would you introduce the idea of medications to them? Because I sense there's always like a hesit, or not always. I see a lot of
Mhm.
people that are really afraid of starting a
Mhm.
medication because they think it's going to be something they have to be on long term.
That's a great question, Naz. And this comes up so often with my patients, and we really have to meet the patient where they are, right? And everyone's going to be a little different, and some things are going to be consistent across patients. But I often start by asking, you know what, tell me more about your hesitance. What makes you feel uncomfortable about the potential of starting the medication? And I remind them, I'm not here to push it on them. Like I get, I have to remind people there's still a lot of myths around kickback that doctors may get for prescribing these medications. I'm like, I promise you, I'm not getting any money for prescribing it or promoting it
Right.
anyway. So it's really up to them. I remind them that I'm here to educate. But when I ask patients, like, what is it that is causing you hesitance? You hear some patients say, well, I just don't want it to change my personality and my brain. And I have to remind them that it's not going to change their personality. And to the degree that it might change their brain, that would be for the better, because the brain is, obviously symptomatic. It's being impacted. It's the thing, the organ that's suffering at the time. And so any change would be for the better. And also, most changes aren't permanent. The reality is if something doesn't feel comfortable once they start the medication, it's reversible. We just stop the medication. They go back to where they were. Even if it helps, we stop the medication. And some patients are still going to go back to how they were feeling prior to medication. I also dispel other myths. So some patients are like, well, I don't want to be addicted to it. And SSRIs
Hmm.
are not addictive. And so I have to, provide education about that. Like, this is not, it's like I tell them it's more like high blood pressure medications. And I can appreciate where the idea of addiction comes in. I mean, we talk a lot about SSRI withdrawal, and the term withdrawal is, very much connotated with addiction and drug, abusive substance withdrawal. And I have to
Hmm.
remind people that, yeah, you might, yeah, possibly someone could feel something when stopping these medications, but it's not addictive. Their body is not, has not gained the tolerance, and they're not going to crave it. No one's going to be like, I was craving that, sertraline, all week after I stopped it. No, it's not going to happen. So reminding them that it's not addictive. None of these SSRIs are addictive, and with appropriate tapering, they're typically easy to come off of. And going back to my analogy to high blood pressure medication, I remind them that just like you're prescribed high blood pressure medication, you take it, it lowers the blood pressure, you stop it, your blood pressure goes back up, and this is commonly what we're going to see with the use of antidepressants. You start it, ideally it helps the depressive or anxiety symptoms. You stop it, those symptoms may come back. But with appropriate treatment for a new onset depression or anxiety disorder in the context of pregnancy and postpartum, we sometimes see those symptoms
Hmm.
fully remit. So after a year of treatment, the symptoms may not come back, and that's less suffering. So I remind my patients of that too. Like, how long do you want to suffer? How long do you want to kind of wait this out? And I'm there to support them for however long they want to wait it out.
I think so. Every time we do this, I write down a few more pearls that before I go see a postpartum patient,
Mm,
I look at to use because I think so much of this is also as we get used to doing something that is not in our wheelhouse, it's like seeing what our peers and the experts are saying. So, one thing that really stuck with me here is most change isn't permanent. Like, that's such a
mhm.
powerful one, I think, for
Yeah.
people to hear and to remember that like you said, we're not trying to change your entire makeup, and it's okay to give this a trial.
Mhm.
We laughed at the addictive part, but I do think that is a big thing in people's
Yeah.
mind. And then when you think about I want to come back to this because I want us to be able to talk a little bit more. But like at my health system, our neonatologists come to the room, we say we page a nine or we page a certain number
Mhm.
when there's a
Mhm.
patient who's been on an SSRI. And
Yeah.
it
Yeah.
I've struggled with it because in their mind, it's not anything. They just want to make sure the baby looks okay. But
Mhm.
also, in talking to the patient about their mental health, I'm saying, don't
Mhm.
worry, it's safe. And that's going to be my next question. It's safe. But
Mhm.
at the time of delivery, we're going to have extra people there. And
Yeah.
maybe it's a me thing. Maybe I need to figure out how to frame it. But there was an FDA panel in the past few months that thoroughly
Mhm.
confused the general public about the safety of SSRIs. So, can you remind us and give us a few pearls that we can share with our patients about the SSRI safety?
Yes, yes, for sure. Yeah, so, um, yeah, that was a very confusing panel. What I want people to take away from this wonderful question, a very timely question, is that there are risks on both sides. So I actually never say safe. We have no definitive way of knowing what's the also, that it's definitively safe. But we also have no definitive way of knowing that any medication that we give a pregnant or lactating woman is definitively safe. Why? Because we've never done randomized controlled trials in a person that is not lactating or is lactating but has no indication for taking the medication, meaning they're not depressed, they're not anxious, they have no mental illness to take the medication for, and gave them the medication and just saw what happened to the baby that was exposed to it. So we have
Mhm.
no way of completely knowing, but with our best data, which we've studied SSRIs ad nauseum at this point, more than many other medications that we give pregnant women, um, we are not seeing any adverse outcomes that are long lasting. So no congenital malformations, no neurodevelopmental effects. When we talk about neurodevelopmental effects, we're talking about, intellect, so and social development and cognition. So we are not seeing, an impact there. But that's one category of risk. The other category of risk is the illness itself, the untreated illness where mom is depressed, mom is anxious, and she is either pregnant or postpartum, and the exposure to her own anxiety or depression. It's not, I tell people everything that is happening in the brain is not just stuck there. It affects the whole body. And when we start to think about the impact of toward the body and the stress hormones that are circulating and impacting the fetus or impacting the developing infant because of mom's interaction. Not She's not doing anything wrong per se. She's not trying to do anything wrong. Doesn't mean she doesn't love her baby, but there is definitely impaired interactions that she's not even aware of that are impacting a developing infant, and those have actually been shown to have long-lasting impacts on the fetus who becomes the baby or the developing infant. So we're talking more prone to developing mental illness such as anxiety and depression, more delays in cognitive, social, and emotional development. And so when we compare those two risks, untreated illness and exposure to SSRIs, whether that's during pregnancy or in breast milk, we're trying to balance, well, what's gonna be best for mom and baby. And what the
Mhm.
FDA panel did not do, which we would love to see more of, was really tease that out. Okay, well, if we don't
Mhm.
treat, then what happens? And one of the
Mhm.
panelists did address this, but there wasn't a lot of discussion around it. I don't know
The
that that point
MFM.
really. Yeah, the MFM
Yeah.
addressed it, and I don't know if that point got driven home enough. But there was consequence in not treating, and I think we have to remember that. Just like there would be consequence if we didn't treat diabetes in pregnancy or
Mhm.
postpartum or epilepsy. Like there's consequence, which is why we treat in the first place.
I think that's so important. And I like that framing a lot of exposure. And that's something I'm going to say it so that I remember to use it with patients too,
Yes.
like that exposure to SSRI versus untreated illness. And in the
Yeah.
newsletter, I've always highlighted studies that have showed, just like you said, the decrease in bonding, the impact on the spouse and the rest of the family for mental illness.
Hmm.
And I believe there's some data too that there's an association with um, mental health conditions on increased risk of preeclampsia in future pregnancies
Hmm.
or small for gestational age. I don't know how well,
Yes.
that data is tied out, but but we are seeing, like you said, the impact of untreated illness. And I think importantly, your framing of not mental health and what is happening in our brain is the same as what is happening in our other organ systems and our
Yes.
approach to them, right? Like our heart or our pancreas with the insulin. So I
Yes.
think that's a really important one. Let's make sure, and there's a great comment about just what barriers to using medication that we'll get to. Are there any SSRIs that are more risky or shouldn't be prescribed in pregnancy?
I would say no. And I'll
Okay.
highlight, I'll go ahead and address the elephant in the room because everyone's like, what about fluoxetine? And
Uh-huh.
fluoxetine, yes, there was that black box warning some years ago for concerns of heart, increased risk for heart defect or cardiovascular malformation. And that's since that finding years ago, there's been better data that came out addressing confounding factors. So adjusting the data for confounding factors. Maybe a confounding factor is the mom smoked or there was heart disease in the family
Mhm.
or something like that. And once these investigators address that, the signal for an increased risk for cardiovascular malformation drops significantly to being non-existent essentially. Now that's only been a
Okay.
couple of studies to show that. So we all still kind of proceed cautiously, like, okay, we're not going to start with paroxetine. That wouldn't be my, starting medication. However, if someone is already taking it and it's the medication that works great for them, we would not stop it. So it's not our
Okay.
first line SSRI, but we're not based on more recent data, we're not worried about it such that we would discontinue it.
Okay. That's great to know. And
Mhm.
then do you use the same SSRI to treat anxiety and depression, or do you think about it differently?
I use the same SSRI to treat anxiety and depression. Again,
Okay.
different people respond to different medications. I tell my patients this all the time. I'm like, that's partly the reason we have so many SSRIs because one size does not fit all, is what we've learned.
I say the
But
same for combined
yeah,
oral contraceptives, right? Just
yes,
because you
yeah,
didn't do well with one doesn't mean you won't do well with the other. Um,
exactly. So yeah, no
and then
particular reason.
Well,
Yeah.
great to know. And I think when we go over a few of the different types, could you tell us if there's a
Mhm.
dosing? What I don't always understand is there a dosing that's better for anxiety versus depression? Like if I'm starting
Mhm.
someone on Lexapro, but I'm more
Yes.
I'm more worried about anxiety versus depression, how should I think about it? So
Yeah.
well,
Oh, great question. Yeah. Mhm. Yeah, I
if
can
that's
go over that
something,
now or I can wait until you're ready.
which would be easier for you when we go
Yeah,
medication by medication or now?
yeah, yeah. Medication by medication. We can wait.
Okay, sounds good. And then how do you counsel, like, what do you say about SSRI exposure and breastfeeding?
Yeah. Yeah. So now this varies from drug to drug. And so, this may be one of the reasons many of my OB colleagues may start with sertraline. And that is because there's, almost no transfer in the breast milk with sertraline and, or the quantity is so small that it's barely measurable. So that's appealing to, the prescriber as well as the patient. It's like, okay, I barely have anything. The breast milk is going to be barely any exposure. That's ideal.
Hmm.
However, everyone does not respond to sertraline. So when we're thinking about other SSRIs, most of them have low amounts in breast milk as well. Not quite as low as sertraline, but are fine to use. One of the ones with the highest transfer is fluoxetine, and still it's fine to use in breastfeeding, but it does have higher transfer. And of course, we're, always encouraging patients to let us know if, the baby is more sedated in any way, more fussy, or any changes. They should let us know as well as the pediatrician. But I can tell you in my 15 years of practice, I have not had anyone complain that they're noticing any changes in their baby.
Great to know. And then I think probably everyone here is familiar, but mothertobaby.org is such a great website to look up medications and
Yes,
also give fact sheets to patients. You just go and look
absolutely.
up the fact sheets, look up the medication, and you can send it to the patient. Let's get into some of the um, into the details about the different doses, and
Yeah,
then we'll leave some time to answer questions. But let's start with that sertraline or Zoloft. How would you
yeah.
start a patient? How would you titrate it, the medication, over what time course? What do you
Mhm.
tell patients for when they'll feel an effect? And how would you think about the depression versus anxiety aspect? I
Absolutely.
ask so
So,
much of you.
so how I tend to titrate, I'm going to start with pregnant patients. So, pregnant patients, I'm
Mhm.
titrating a little quicker, mainly because they're pregnant. There's more volume on boards. There's also higher metabolism. And I don't always know the genetic makeup of the patient in terms of are they a rapid metabolizer or not, but I know that we're trying to get them well quicker. So for a drug like sertraline, I would start with the typical 50 milligrams in pregnancy, and um, and then give them, a month to see how that's going. If they're tolerating it okay, are their symptoms starting to improve, and then I would go up. I don't wait the full 6 weeks. If you'll know, like if you're seeing improvement, you'll know by that 4 weeks if you're headed in the right direction. If it's not completely remitted in those 4 weeks, I go up. Um,
Okay.
so I'm seeing that
Did you
person
say
monthly,
five? You said 50 milligrams.
50. Yeah.
Okay, great.
No. If they were postpartum, however, I would do that a little bit
Hmm.
differently. And this will be the same pattern, walk through the other medications, but uh, I would start a little slower. I find that some of my postpartum patients, or many of them actually, especially with something like sertraline, the serotonin concentration is high. And if they are naive to SSRI, that can just, the adverse effects of starting that agent can feel just jarring. And then that's going to make them less likely to want to continue the medication, right? So I might,
Okay,
depending on how anxious they are about starting it, I might start as low as 25 or 12.5 to ease them into
okay,
it and let them take that for 1 to 2 weeks and then go on up. So if I'm starting at 12.5, I'm going to go up in a week because 12.5 is literally a drop in the bucket. I'll go up in a week to 25. I'll give that 2 weeks
hmm,
and go to 50. And then I'll again
okay,
hold at 50 for another 4 weeks, depending on, how well they're doing or not. And then go up further in a month that's tolerated to 100. Now, if they're anxious for sertraline, the max dose I would use would be 300. I'm using 300 often in patients who have OCD, um, particularly severe
okay.
OCD that's just not responding. Once you hit 200, they're still kind of like, yeah, I mean, that helped a little bit, but not enough. I'm going to push it. Yeah.
I'm going to be referring to you when I'm going past 100 or even 150. I think I've never, yeah, I don't have experience, but that's great to know that it's safe to go up to 300. Would you
Yeah.
say the same for depression, or where would you want to be for the depression range?
Yeah, for depression, 200 is usually my max with sertraline. If they haven't had a adequate response by that time, they're probably not going to have an adequate response if I keep going. Um, that's
Okay.
just a general rule. There are some caveats to all of these general rules, but that's just a general rule to follow. Get to 200 if it's not, if they're like, this has barely touched me. I'm just as impaired as I was when I started the medication. Just, it's time to start something else.
Awesome. Let's go on to escitalopram or Lexapro. How would you
Yeah.
approach? I loved how you broke it down, pregnant versus postpartum.
Yeah, so same there. I'm gonna start right at 10. Often people start at 5, but in pregnancy, I'm like, we're trying to get better soon. And again, volume, metabolism, other things, lack of me understanding genetics, again, could be a
Mhm.
rapid metabolizer of the CYP2D6 enzyme. And we know that, there's lots of nuances here, but just again, general rule of thumb, I would start with 10 in pregnancy. For the medication naive patient, meaning SSRI naive patient postpartum, I would start as low as 5. Really, it's really hard to go lower than 5 with escitalopram. So I'd start 5, give it, a couple of weeks, go to 10. You really need to get to 10 for adequate therapeutic dose, unless you just have someone that is exquisitely sensitive to these medications. You can
Okay.
go as high as 40. Now, a lot of people
Okay.
don't appreciate that. It's like they hit 20 and they're like, she was doing better, but not quite there. And they stop the whole medication and start over. And I'm like, no, you should push it to 30. And I really often don't need to go over 30, but for a patient with OCD, I definitely may push it to 40. And but 30 would be fine for someone's dealing with depression or anxiety. Pushing it to 40 if they're dealing with anxiety. Um, it might be helpful, and especially if the anxiety is OCD.
And is there a trend where with OCD you're going to use higher doses of the SSRIs?
Absolutely. Yeah.
Okay,
Yeah. In
that's
most
helpful to
cases,
know.
it's rare. Not guaranteed, but it shouldn't be surprising if you see someone where you hit the typical max dose and they're not responding. It's normal to just go a little bit higher and see if, or not that they're not responding, but they haven't responded fully. Because by the time you're getting to that dose, you
Mhm.
should see some indication that they're responding, which would encourage you to keep going with if you're dealing with OCD.
Good to know. And do you think any differently for anxiety versus depression?
Yeah, just like I said, the
I might
anxiety.
have missed it.
Yeah, no, it's okay. Anxiety, I would go as high as 40,
Okay.
whereas depression, I wouldn't go over 30 for escitalopram.
Okay. 40.
And
Okay.
still 30 is more than the 20 that is on the label, on the package insert. We do a lot of
Okay.
different things in real world practice versus what's on the package.
Totally. But this is why it's so helpful to hear it from an expert
Mhm.
who's doing this every day. How do you think about the side effects for the sertraline and the escitalopram? Are they similar? Are they going to be different?
Yeah, side effects are typically similar, warning patients about, GI upset and that initial start the first few days to a week, but telling them if it continues for a week, our goal is not to create another issue. So we're going to stop if they're having diarrhea, prolonged constipation, headaches, triggering migraines or something like that. I do warn patients
Okay.
about sexual dysfunction as well, particularly women. We know that at least 30% of women will have some sexual dysfunction or side effect as a result of taking an SSRI, not being decreased libido or difficulty climaxing. And, I let them know about that. A lot of times when patients respond, either A, they're like, I'm so depressed. Sex is the last thing I'm worried about right now. But they
Hmm.
will be worried about it again at some point. And so I remind them that that's something we can address at the time. They may not need to take this, more than a year. So it may be a non-issue. It may not affect them in that way at all. But just to let me know if it does come up when they are sexually active again.
That's helpful. And I know I would love to in the future have a webinar with you where we talk about are there
Mhm.
certain medications that might be better for those sexual side effects. So thanks for
Yeah.
reminding me of that. How about fluoxetine?
Mhm.
How would you
Yep.
consider, you mentioned it a little earlier, but how would you consider using fluoxetine?
Yeah, fluoxetine. Again, I use it often now. I will say this, that for some reason, some people gain weight on this particular one. And so again, it's not my first go-to. I don't really have any other reason that I wouldn't prescribe it. It is a um, higher amount of transfer in the breast milk, but again, there's been no studies that showing that it's not safe in terms of its exposure in
Hmm.
breast milk or low risk, as I would say. Um, but yeah, because of the potential for some to gain weight, it's not my first go-to just because, again, I'm not trying to create another problem for anyone. Of course, in pregnancy, who knows the difference? People are gaining weight anyway. But if I'm starting to get postpartum, definitely, trying to be aware of people trying to lose weight and not going to be happy
Okay.
with if they're gaining.
Do you think is it more than I had generally, my understanding was that Paxil was one of the SSRIs that had the most weight gain. Is that correct? Or how would you compare the two? And what, like I say, 10% of people will gain weight, up to 10% will gain weight on Depo. Do we have a number like that for
I
fluoxetine
am
or?
not aware of and I would have to check the more up-to-date data to see if there is something out there. I'm not aware of a good stat on that, so we can definitely get back to you guys if there is.
Mhm.
But in terms of paroxetine versus fluoxetine, I find it very variable, and it's in my anecdotal experience that um, yeah, some people don't gain weight on either one. Others gain weight on
Mhm.
fluoxetine and not paroxetine. Others on paroxetine, not fluoxetine, and some on both. And yeah, it's very much a if they must go there, if that is like we've tried some others and we're gonna try this one. Um, I'm just monitoring, trying to see if if they're having. It's kind of hard to based on not having trouble losing weight, but if they are gaining, and it's just
Mhm.
excessive gaining, then I'm definitely monitoring that. And it's usually unusual for someone to start gaining, 10 pounds in the midst of
Mhm.
breastfeeding. So that's always a kind of a sign that, okay, maybe we need to try something else.
Sounds good. And how would you consider the fluoxetine dosing pregnant versus postpartum?
Yeah, so pregnant starting at the typical starting dose, which is 20 milligrams. Postpartum, again, starting a little lower at 10 milligrams. And I
Okay.
go up by 20s. A lot of times now, some people feel better going up by maybe even the patient will feel better going up by 10s because they feel like they're taking less. I
Hmm.
anecdotally don't really see a get unless they're really sensitive to the medication, it just slows down the process really, and the time for them to
Hmm.
get better. So I tend to dose like, going up by 20s every 4 weeks, um, until they're in remission.
Okay. I'm just seeing so many parallels with menopausal hormone therapy as you speak and
Mhm.
how we think about dosing hormone, like the
Yeah.
estrogen and everything. What is your goal for depression versus anxiety in terms of dosing?
Yeah. So the max is typically 80. I may push that a little
Okay.
bit more for 80 for depression specifically, whether you're
Okay.
pregnant or postpartum. And I may push that a little bit more if we're seeing improvements. And, if there's a patient that has anxiety, we're seeing improvement, but we get to 80 and it's not quite, just not quite fully remitted yet or as good as we think we can
Hmm.
get it. And I'll, push to 100. I've seen doses as high as
Okay.
120, but yeah, usually, at the point you get to 100, 120 is not doing enough for the anxiety. It's
To
just a good,
switch.
good time to switch. Yeah.
How do you, one thing that I've started telling patients, because I see a lot of 40-year-olds who are having hot flashes, and I tell them
Mhm.
not every hot flash is related to perimenopause and menopause. And we know that in postpartum, there's a similar
Yeah.
physiologic impact of the change or the fluctuation in the estrogen.
Mhm.
So, are there any of these three that we reviewed that might make someone more prone to hot flashes or night sweats?
Great, great question. I do have some random cases of like people coming in with hot flashes, night sweats, and they're in that age range where it makes it really confusing. And I don't know that we
Yeah.
understand that well enough because,
Okay.
yeah, there's just we don't I don't think we've really captured when people hit perimenopause before they start to have those changes in their menstrual cycle. And I do believe that
Mm-hmm.
I'm seeing some people hit it, like they're having the hot flashes, vaginal dryness, but they're getting their period every month.
Yeah.
And yeah, and it's like I don't know what to I don't know what to tell them.
I'm
They
not
will
going to
ask
speak from experience or anything, but
yeah. So yeah, those cases are hard to tease out, and I'm like, we can stop the
yeah,
medication, we can see if that's the culprit. Often it
yeah.
doesn't help. Just I stop it, and they still are having the same symptoms. But yeah,
Yeah.
but to your point, yeah, it's always worth exploring whether the medication could be causing that. Sometimes it is.
Awesome.
I would say that's not a common thing. Like, it's not like 50% of
Okay.
patients are experiencing this, but it
So
can be an adverse
happen.
effect. Mhm.
I know we have 6 minutes left, and I want to leave a few minutes for
Yeah.
questions, but I'm dying to hear about bupropion and Wellbutrin just because I'm not used to prescribing it. I wanted to hear from you, like, can we give it to this patient population? Who should we
Yeah.
be thinking about it for? And how would you dose it? Because my understanding is it's really great for people because it doesn't have the same sexual side effects. So if people are
Mhm.
really worried, that's one that I should be considering. And it has more of an appetite suppressant.
Mhm.
Again, if I'm correct, effect. So some people might, I've, at least in my perimenopausal patients, and I know, again, we're talking about pregnant and postpartum, it's something that may be more appealing if there's a risk of weight gain with some of the
Yeah.
medications.
Yeah, no, bupropion, also known as Wellbutrin, in terms of the brand name, great medication. I use it for depression mostly, or as an adjunct if someone is having a sexual side effect with an SSRI. The adjunct would be a 150 milligram dose, and that usually will help most patients, not all, to get rid of that sexual side effect. But yeah, to your point, appetite suppressant, we actually combine it with other drugs for weight loss. It has mild stimulant effects, so people enjoy the energy and the focus it gives some patients. It's used for very mild ADHD sometimes, so
Mm.
so people get that benefit as well, and a lot of people like it, and it's it yeah, it doesn't cause the sexual dysfunction itself. What's the caveat to this one, though, is that as you get higher in doses above 150, if you use an extended release formulation, it can increase anxiety. So you have to be careful with it. So when you hit 300 or 450, you have to ask the patient, and sometimes they'll just tell you, I'm feeling more anxious, in which case,
Hmm.
yeah, it's not going to be the best drug for them. But a lot of people do tolerate it well. It's also used for smoking cessation. So if you have a patient that's struggling with that, um, you know, some people find it helpful with pain syndrome. So
Hmm.
it just kind of it can be a very comprehensive medication and yeah, and helpful in that regard.
Should I be thinking, because I see a lot of pregnant patients who have ADD, ADHD, who came off of their medications very intentionally, not wanting to be on any kind of stimulant. And they also have a history of like a depression or anxiety. Should I be thinking of a Wellbutrin in the pregnancy to start them on if they're having any concerns?
Yeah, that's definitely one to consider. I will say that it's not as potent as amphetamine, so it's not going to
Hmm.
typically be as effective as Adderall or Ritalin or some of these other stimulants that people might have been taking, but it does provide some increased focus. I must say that our data on it in breastfeeding, there's still more data to be had. I don't stop this medication if my patient is taking it and doing well on it and breastfeeding. However, there have been 2 cases of cyanosis, so the baby having difficulty breathing, turning blue, in the context of
Hmm.
breast milk exposure to bupropion. And the challenge with these cases is it's been 2 over all the years it's been prescribed. And, you know, did
Okay.
the
Oh,
mom
so
have
two
something else?
cases in the total of
Yeah.
everything.
Yes.
Which I don't
So
know that number, but it's probably thousands.
yes. So, does that
Okay.
mean, we're trying to figure out the mom, baby have something unique going on, and we can't answer
Hmm.
those questions to really fully understand what may have been the precipitant in that case, in those cases. So we keep that in the back of our head. We tell parents about it. Just look out, see if you see any differences. But for the most part, the data has been reassuring on breast milk exposure to it. And yeah, we wouldn't necessarily stop it, but again, probably not our first line, just for that reason.
Okay. And would you start, so in pregnancy, would you start at 150 and maybe go up to 300 and then would it be different in postpartum or it's about the same?
It's about the same because if you're using the extended release, which allows you to dose it once a day, it's hard to break that up any other way. But you can
Yeah.
use sustained release and do 75 twice a day, which could be a good option in pregnancy, actually, that help further help keep a level concentration. But the extended release is fine. And then there's immediate release, which people have to take twice a day, which people just don't like taking medications twice a day.
Mhm.
So yeah.
That's amazing. Thank you. I know we're almost at time. Let's go to some of the questions we had. This was, and I think we have to do this again because it's just such a helpful one. Um, is there, you did mention this, and I think Marisol, we did go over this for the dose difference of anxiety, depression, OCD. We didn't talk about PTSD specifically, but one question was, how can a therapist monitor medication efficacy?
Yeah, so monitoring medication efficacy, of course, you got to ask the patient how are they feeling, and get specific. Not like, people say I'm feeling better, but what's feeling better? Like, and people can
Hmm.
tell you if there's really a true difference, they will give you examples. But another way, systematic way to do it is to keep repeating the PHQ-9 or the EPDS, and compare that to where you started when they started the medication and what they're checking off as they're coming in for each visit. And that will also, I think, I usually do both, and they're helpful because sometimes they'll say I'm better, and they've marked like a 15 on the EPDS, which anything above a 10 is positive, and I'm like, okay, well, how much better are we? Exactly, based on,
Hmm.
I'm looking at your score and, you know, tell me more about these different symptoms. Yeah.
That's really helpful. Um, I think there was a question, if you want to answer it individually for the person who asked about psychotropic. Well, actually, this is important. Someone worked as a therapist in a rural area, and the psychiatrist that clients would see would always take them off all of their psychotropic medication as soon as he learned of their pregnancy. Is that typical? Is the profession working to educate psychiatrists about this?
We are working to educate psychiatrists, OB-GYNs, family medicine docs, pediatricians, nurse practitioners, but I don't know why the education is not spreading quick enough, especially for, SSRI specifically. And then you have things like the FDA panel, which complicate matters. But being in the rural area, obviously, if they're not reading and up to date and participating in CMEs related to perinatal mental health, it can be easy just to not, to be practicing kind of old school. And years ago,
Hmm.
that may have been the approach. Um, yeah, I just think I still see this with other practitioners, and I educate my patients, and I try to educate the doctor. I send them medication articles, mother to baby, lactmet. Like, this is where we are
Yeah.
today. Just wanted to share with you, this is what my recommendations were based off of. But that's definitely not best practice to stop everything.
This is where I think mothertobaby.org is a really useful resource, and going to the fact sheet and printing it out and gives the patient some reassurance and can also serve as some CME. But I think I see it as well. And I'm sorry, Crystal, if you have time for this last question, because I think it's
Yeah,
important.
I'm fine.
What what do you recommend for anxiety until the SSRI kicks in?
Yeah, great question. So typically I'm using like Benadryl or something, which is not always the preferred medication because it can make someone sleepy, right? If they can sparingly use Ativan, that's fine. It's not the
What
worst
is
thing.
sparingly to you? Is it like a zero
Yeah,
point
sparingly
0.5?
is like once a week, twice a week at most, but not
Okay.
daily.
Okay.
And not for a long period of time. When we're saying when it kicks in, or what if you gotta like titrate up to 200 and now we're like using Ativan for a prolonged period of time, over a couple months, using it once or twice a week, especially if they're postpartum. But I believe, Nas, I feel like OBs are okay with sparing use of Ativan like once or twice a week as
Hmm.
well.
I was gonna
And
say, I do like
yeah.
even once every 2 days, I'd be okay with.
Okay. Yeah, okay. So
Do you use do you use like a hydroxyzine ever? I feel like I've
yeah,
seen that a lot.
hydroxyzine, Benadryl, similar in terms of mechanism and everything. And yeah, it's just that these all of them can make you sleepy, including the Ativan. Just the Ativan wears off quicker. Um, so
Okay.
we're always keeping that in mind. Seroquel would be another one, but a lot of people they hear antipsychotic and freak out. So
I was
yeah,
gonna
but low
say,
dose.
I think this we might not be at that. Maybe that's another
Yeah.
webinar where we talk about
Yes.
dosing that. But that's helpful to hear. I think because when I see Seroquel on someone's med list, I always go to antipsychotic. I'm not thinking of it as being something that we're using for anxiety, and
Yeah.
I should open my mind to that.
Yeah, anxiety and sleep. Low doses like 25 or 50 might be, used as needed for anxiety for some patients. This is not like, the most standard practice, but it does help some. And it's become very used for sleep, like 50, 100 milligrams.
Okay, thank you. Crystal, we could keep going. I'm taking notes as we speak, but this was super helpful. I hope I got a lot of pearls from this. I hope everyone will be able to take this away
Yes.
and prescribe an SSRI for a patient rather than making
Yes.
them wait and feel comfortable about what to expect. So thank you for sharing your knowledge with us and to the providers who joined us today. We hope you found this engaging and informative. And just a reminder, because I do have to plug Seven Starling, we are seeing patients in 19 states. And Crystal, when you and I started, it was three. So
I
now we're at
know. Isn't that
19
amazing?
states. Yeah. Ohio is our latest. Our Medicaid expansion continues, and Seven Starling now accepts Blue Cross Blue Shield Medicaid in North Carolina, as well as Maryland, Texas, Virginia, and DC. We are committed at Seven Starling to providing a full spectrum of women's mental health care and would love to support you and your patients. You can always check out our website. But Crystal, thank you. This is always one of my favorite
Yes.
things. And I just appreciate so much the learning that we have together. So hopefully we can do this again in 2 months or so. I have recorded this. We can have the recording available and send it out to people if you want to share with anyone. But I also love doing this at least once a year because I learn something new each time. So,
Yes, yes. Well, it's always a pleasure. I hope everyone was able to take away something, and we will look up that stat. I'll look that up.
yeah, we'll get that next time. We'll talk about side effects more next time
Yes.
too. Have a
Okay.
great day. Have a
All
great
right.
night,
Take
everyone.
care, everyone. Bye.
Bye.